Hi, my name is Talib Omer. I'm one of the ultrasound faculty at USC in Los Angeles, and this SAM lecture is about the utility of point-of-care ultrasound in patients with suspected or confirmed shoulder dislocations. While comprehensive shoulder ultrasonography has long been used as a valuable tool to evaluate the shoulder joint and its intrinsic and extrinsic muscles and tendons in the non-emergent setting, the point-of-care application in shoulder dislocations for emergency providers is fairly new. However, it can easily be learned and can be extremely valuable. But first, let's go over the outline of this lecture. First, we'll talk about why this is an important and valuable application to know in the emergency department. We will briefly go over the existing literature, review the relevant anatomy, and go over the technique and what normal anatomy looks like on ultrasound. We'll then go over a few cases and pitfalls, and finally, we'll discuss joint injections and the suprascapular nerve block and shoulder dislocations. But why shoulder ultrasound for dislocations? Well, for starters, the shoulder is the most commonly dislocated joint in the human body, with an incidence of about 24 per 100,000 per year. So this is bread and butter emergency medicine. And according to literature, an X-ray has an average turnaround time of about 40 to 65 minutes, in some instances even up to 2 hours. So ultrasound can not only lead to expedited care, but also to a decrease in cost and resource utilization, and of course a decrease in radiation. But other than time savings, a probably even more important reason is the following scenario, and I'm sure we've all been in this. What do you do if you're performing procedural sedation on a patient and you really tried hard to reduce the joint, but you're just not sure if the shoulder is reduced or not? Are you going to wake the patient up from sedation and get an X-ray and then try an hour later, submitting the patient to yet another procedural sedation? Imagine a tool where within seconds you will know if the shoulder is dislocated or not. And then finally, another advantage is that using ultrasound can really help you identify the empty glenoid fossa to do a quick ultrasound-guided injection of local anesthetic into it. It's been shown that actually shoulder joint injections are comparable to pain relief patients get from procedural sedation, with the same success rate in reduction. So let's go over the literature on ultrasound and shoulder dislocations. So slowly we start to have more and more evidence to support its use. Until just a few years ago, we mostly just had case reports. But then in 2013 we finally saw bigger studies coming out. The first two were actually out of Iran. However, they both used, as we find, the more challenging anterior approach. And additionally, the images were interpreted by radiologists attending and not by EM doctors. In 2016 and 17 we had several larger studies that actually all showed a sensitivity of 100%, and except one study all had an excellent specificity as well. That one study that was unfortunately not included in the meta-analysis, seen here at the bottom in green, that was done the same year. That meta-analysis actually found 100% specificity in all studies, with most having 100% sensitivity as well. So overall, these are excellent numbers. Let's go over technique. The curvilinear transducer is the preferred choice as it gives you a large overview of the area, but using a linear probe, especially in skinny patients, is acceptable. The operator stands behind the affected shoulder with the probe marker pointing to the operator's left, so that the indicator on the probe correlates with the indicator on the screen. Now, to get the view we want, we start laterally at the humerus and sweep the probe up until we find the top of the humeral head, and then slide the probe slightly posterior until we see the joint space where the humeral head is articulating in the glenoid fossa. In this clip, you can actually identify the round humeral head, the glenoid and the labrum, and the muscle that sits right on top of the capsule is actually the infraspinatus. And you can see that the humerus is nicely sitting in the glenoid, as it should be in a non-dislocated shoulder. You may also read or hear about a method where you can find that same posterior window by just palpating the scapular spine and placing the probe parallel and slightly inferior laterally to it. That method is also possible, but we had residents palpate the scapular spine for that purpose, and especially in larger and more muscular individuals, they had a lot of difficulty doing so. So therefore it's easier to stick with the first method. So here, a little bit closer look at the relevant ultrasound anatomy of the posterior approach. We see the round humeral head, the triangularly shaped glenoid, and the scapula on the left-hand side of the screen. And right on top of the glenoid is the infraspinatus as it inserts into the humeral head. And you can easily recognize that the humeral head is approximately in the same plane as the glenoid and the scapula. So this shoulder is in place. Here the same approach is video clip. If you're unsure which of the hyperechoic structure is the humeral head, orient yourself based on the probe marker. In this left shoulder, the humerus will be to the left of the screen. Or what you can also do is very gently externally and internally rotate the humerus of the patient like it's done in this video, and you will notice the humeral head moving, or more specifically in the case of a reduced shoulder like this one here, moving and articulating within the glenoid fossa. But what about this patient here? Initially it might look confusing. We see a few anechoic areas and loss of the ultrasound anatomy that we just learned. But if you look very closely, we see the posterior aspect of the scapula right here, the glenoid right here, and the humeral head to the right of the screen. But notice that it's much farther away from the probe. Remember, this is a posterior approach, so the humerus is anteriorly displaced. Therefore, this is an anterior shoulder dislocation. The gap between the humerus and the glenoid we see is the stretched out joint capsule filled with blood, or hemarthrosis. Here another patient actually with a shoulder dislocation. You can see the glenoid and then the anteriorly displaced humerus on the left hand side. But also what you see in this video is actually a needle going into the joint space. So this provider was injecting lidocaine into the joint space and was recording it live. Here one more time, just to recall what a normal shoulder looks like. The ED physicians treating this patient actually prior to the ultrasound were certain that this was a shoulder dislocation because of asymmetry on inspection. So the ED ultrasound team was called. But it looks like the humerus is in place, right? Well, the patient actually ended up having a scapulothoracic dissociation. But that's just a side note. Important is that the ultrasound image looks completely normal, as it should. But to help with pattern recognition of shoulder dislocation on ultrasound, here are a few more examples of dislocations. Here again we can see the glenoid, and then we can see the anteriorly displaced humerus on the right hand side of the screen, farther away from the probe. This image looks a little bit more messy, but you can see the bright structures, right? And again we have the glenoid on the left, and then the bright structure that's farther away from the probe, kind of the center of the screen, is the humerus. This looks a little bit more difficult, but again, all pattern recognition. You see the glenoid right here, and then the anterior displaced humerus right there. Here another example of a dislocation. However, here the humeral head can barely be seen because it's on the very left side of the screen. Despite that, we can still identify that the humerus is not in place. So to improve this view, the operator should really move the probe more laterally to center the joint space on the screen. So this one here might be tricky. We can identify the humerus, however, it does not look like it's anteriorly dislocated. But also, it's not the same level of the glenoid, but it's way more posterior. And remember, this is a posterior view of the shoulder, so everything at the top of the screen is posterior. Therefore, the humerus is posterior displaced, meaning this is a posterior shoulder dislocation. Also notice all the surrounding hematoma, which is another clue that something might be wrong. Regular radiographs for posterior shoulder dislocations have a fairly high miss rate, therefore ultrasound is a helpful tool in patients with shoulder injuries that have a negative x-ray, but they're still unable to move their shoulders. And just for contrast, one more time, this is a normal shoulder where the humeral head is at the same level as the glenoid. Another pitfall which I see done in learners quite frequently is not scanning the shoulder at the level of the glenoid. For example, by being too inferior, where the humeral head becomes the humeral shaft, and obviously as you slide the probe more and more inferior, it separates from the scapular. Of course, a dislocation cannot adequately be assessed unless your probe is visualizing the level or plane where the humeral head would articulate with the glenoid. So always slide your probe all the way up to the humeral head and look for the triangularly shaped structure, which is the labrum, attached to the glenoid, to be sure to be in the right plane. And if you're not certain if you're seeing the humeral head, again, a very subtle back and forth rotation of the shoulder can help you easily identify it. And if you're still not sure, just like in other MSK ultrasounds, you can always compare to the unaffected side. So lidocaine injections into the joint space of a dislocated shoulders, when done correctly, have actually been shown to be highly effective and can cause pain relief comparable to that of procedural sedation and therefore facilitate reduction. The usual approach for this is the lateral approach. A spinal needle is inserted about 2 centimeters inferior to the lateral edge of the acromion and aimed into the empty glenohumeral fossa. After aspirating serosanguinous fluid and ideally drainage of the hemarthrosis, we inject about 10 to 20 cc's of 1% lidocaine into that joint space. This should always be done with ultrasound guidance, with the ultrasound probe in the same posterior location as described earlier. Now, why do we recommend using ultrasound guidance? Well, we're currently conducting a prospective study at our ED with so far 34 enrolled patients with shoulder dislocations, and we found that in about 40% of all injections that are performed blindly by our residents and faculty, these are not within a joint space. We also found that relying on the ability to aspirate bloody joint fluid prior to injection is a poor marker whether or not the needle is in the right location, as the bevel, for example, could be against cartilage while being within the joint space, or the aspirated blood could be from periarticular hematoma from outside of the joint. Here's an example of this. The patient had a large periarticular hematoma, and the person injecting lidocaine was able to aspirate blood prior to injection despite not being in the right location. Here, on the other hand, a successful injection. We can see the needle nicely go into the joint space, and you can see the bubbles from the injection. However, way too frequently in our study, we actually would see the needle not being in the target location, which is highlighted here in red. In these two examples, the needles were too posterior and ended up in the infrascapular area, which is a very common theme in failed injections. Therefore, I recommend always using ultrasound guidance for injections. Of course, there are other pain-reducing strategies where ultrasound can help, like the interscalene nerve block or a suprascapular nerve block. The latter one is the slightly safer option when it comes to risk of pneumothorax. And we'll quickly go over how to perform a suprascapular nerve block right here. So the suprascapular nerve is actually adjacent to the scapular bone as it comes out of the suprascapular notch, and it's covered by trapezius and supraspinatus muscles and the transverse scapular ligament, which is directly overlying it, and it's located next to the artery, which is marked with a white arrow here. The way to get this view is that the patient should be sitting up, slightly slouched forward, and a linear probe should be placed obliquely right superior to the scapular spine, coming from laterally, very similar to the posterior view described earlier, only this time superior to the scapular spine and fanning slightly inferior. To get the target view of the scapular notch, I slide the probe from medial to lateral along the scapular spine until the notch is visualized. You will then see a little recess which is covered with the transverse scapular ligament. Color Doppler can help identify the artery. A long spinal needle should be inserted in plane, and about 8 to 10 cc's of local anesthetic should be deposited just deep to the ligament. Care should be taken not to inject directly into the notch, as the pleura of the lung is in close proximity, but rather inject just deep to the ligament. This block has been shown to be non-inferior to procedural sedation. However, an older study from 1997 actually showed that it's less effective than the intra-articular injection. Now, ultrasound for shoulder dislocation is a really powerful tool. However, anyone performing these should be aware that certain associated injuries are not meant to be picked up by point-of-care shoulder ultrasonography, like, for example, Bankert lesions or Hill-Sachs deformities, or more concerning, an associated humerus fracture. So, if the mechanism or age of patient raises concern for an associated humerus fracture, a pre-reduction X-ray should be done. I personally don't get them on recurrent dislocators with minor mechanisms, which is a large portion actually of our shoulder dislocation population, but it's definitely a good idea to get them in your elderly, frail patients after trauma or after a significant mechanism. And at least at this point, until it's more widely accepted as an imaging modality, get a post-reduction radiograph to prove to the world pretty much that you successfully performed the reduction. So in summary, this is an incredibly helpful application of point-of-care ultrasonography. You not only save time, money, resources, and improve the length of stay, but you can also likely improve the pain control by injecting into the right spot, which may lead to a decrease in need for procedural sedation. And if you use it during your procedural sedations, possibly avoid a second procedural sedation on the same patient. So thank you very much for your interest in this video, and I hope I was able to make point-of-care shoulder ultrasound and dislocations a little bit more understandable to you, and I hope you will really use it in the future. And finally, I would like to thank Dr. Megan Herbst for her support in making this video possible.